Hello everyone. Today we will be discussing about PCOS. So, what is the ASHRAE ASRM 2003 criteria for diagnosis of PCOS? The criteria is hyperandrogenism, ovulatory dysfunction, and PCOM, polycystic ovarian morphology. Any two of these three, if present, leads to diagnosis of PCOS, polycystic ovarian syndrome. But it also excludes the related or mimicking etiologies. Now, what are the other related or mimicking etiologies that we will be discussing in this discussion? First is hyperprolactinemia. We should always rule out hyperprolactinemia before labeling patient PCOS. Second is thyroid disorders. Third is congenital adrenal hyperplasia. Fourth is ovarian and adrenal tumors. Fifth is Cushing syndrome. And sixth is idiopathic hirsutism. Just little bit about all these things. So all these things you must rule out before labeling the patient as PCOS. Hyperprolactinemia. Hyperprolactinemia, there will be prominent menstrual dysfunction and there will be little hyperandrogenism. While the PCOS woman will have menstrual dysfunction along with hyperandrogenism, but the hyperprolactinemia patients can also have galactorrhea. Okay, so it is diagnosed with galactorrhea and serum prolactin levels. Serum prolactin levels can be mildly raised in patients with PCOS, but that doesn't mean they have hyperprolactinemia. So they can be more than the baseline levels. Like usually the PCOS woman can have somewhere around 35 to 40 or maybe 45 the prolactin levels. So the hyperprolactinemia must be ruled out before we make a diagnosis of PCOS. Another are thyroid disorders. So thyroid disorders are associated with menstrual dysfunction, as well as PCOS is also associated with menstrual dysfunction. So, but in thyroid disorders, there will be other manifestations also, whether it is overt hyperthyroidism or it is hypothyroidism. The manifestations, as we all know, the hypothyroidism will present with the dry skin, the slow pulse, all these things will be there. The cold, clammy feet, the hands, all these problems will be there, and vice versa for hyperthyroidism. So, the thyroid disorders can be easily diagnosed with free T4 level and TSH level. So, it's just a simple test which we can do in a fasting state. Then coming on to ovarian and adrenal tumors. So ovarian and adrenal tumors will present with severe hirsutism, and that will be rapid onset hirsutism. So that differentiates between the PCOS woman and the adrenal and ovarian tumor patient. And the level of testosterone will also be very high in the patients with tumors as compared to the patients with PCOS. Usually the testosterone levels, they do not cross 5 millimole per liter in patients with PCOS, but in tumors the level of testosterone is very high. So they can be diagnosed with serum testosterone level. When taken in nanogram per dl, it is more than 150. So in patients with PCOS, the testosterone levels will mostly be less than 150 nanogram per dl. In adrenal tumors, there is a marker DHEAS because it is only produced in adrenal gland. So that is a specific marker which can differentiate ovarian causes from adrenal causes. Ovarian tumors are excluded by ultrasound and adrenal tumors can be excluded by CT scan. Congenital adrenal hyperplasia. This we need to rule out before labeling the patient as PCOS. And how will we do that? Usually the congenital adrenal hyperplasia, it will present with early onset hirsutism. And there will be severe hyperandrogenic features. while PCOS women will have slow onset hirsutism, and the hirsutism might not be so severe, while in congenital adrenal hyperplasia there will be very severe hirsutism. One easy way to diagnose, to separate the CAH patients from PCOS patients, is the breast examination. The patients with PCOS will have plump breasts. They will have the Tanner staging for the patients with PCOS will be 5. But with the patients with CAH, they will have the smaller breasts. Why they will have smaller breasts? Because of the high testosterone levels. But in the patients with PCOS, although testosterone levels are high, but they are not so high as the CAH patients. So that's why the breast will be plump in patients with PCOS, while the breast will be atrophied in patients with CAH. So it is diagnosed by 17-hydroxyprogesterone, which is more than 200 nanogram per dl. ACTH stimulation test can be done. Post ACTH stimulation test, the 17-hydroxyprogesterone will be more than 1000 nanogram per dl, which is more suggestive of CAH. Fifth is Cushing syndrome. Cushing syndrome is associated with menstrual abnormalities, hyperandrogenism, and central obesity. And it can be diagnosed by overnight dexamethasone suppression test. The value less than 1.8 microgram per dl is normal. Last is idiopathic hirsutism. Some patients can have increased peripheral 5-alpha reductase activity. 5-alpha reductase converts testosterone to dihydrotestosterone, and it is associated with normal menstrual cycle and normal testosterone levels. So idiopathic hirsutism can be easily diagnosed because the menstrual cycle will be normal and the testosterone levels will be normal. So all these things we must rule out before labeling the patient as PCOS. So after exclusion of all these pathologies, then only we will tell the patient has PCOS if she has 2 things out of 3, that is hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology on ultrasound. Thank you.